Welcome to the short review series, and the topic we are now going to discuss is parathyroid gland. Parathyroid gland is gland located behind thyroid gland. These are two pairs of glands which are located behind thyroid gland. These are tiny glands, and embryology of the parathyroid gland is it develops from superior parathyroid gland develops from fourth pharyngeal pouch, and inferior parathyroid gland develops from third pharyngeal pouch, and the thymus also develops from third pharyngeal pouch. So this is development embryological point of the development of parathyroid gland. And the surgical anatomy of parathyroid gland is these are four in number and weighs up to 50 milligram. Superior parathyroid gland has different nerve supply, blood supply, while inferior has its own blood supply and nerve supply. Superior parathyroid gland are more consistent in position than inferior, and they are found lateral to recurrent laryngeal nerve. So during a surgery of the parathyroid gland, we have to take care of recurrent laryngeal nerve, because damage of recurrent laryngeal nerve can cause hoarseness of voice. Yes. These are found above inferior thyroid artery. So these are anatomical landmarks of superior parathyroid gland, and inferior parathyroid gland are more variable in position than superior one, and they found medial to recurrent laryngeal nerve. These found lateral, and these found medial to recurrent laryngeal nerve, and they found below inferior thyroid artery. The inferior parathyroid are more likely to be ectopic, and most commonly uh, tail of thymus. More common ectopic site are infrathyroid site, are mediastinal site, are tracheoesophageal site. Ectopic parathyroid gland most commonly at tail of thymus. They develop most commonly at tail of thymus, are at mediastinal level, or at intrathyroid level, tracheoesophageal groove as well. Inferior thyroid artery supplies uh, both superior and inferior parathyroid artery. Now, physiological point of the parathyroid gland secrete parathyroid hormone, which has function in response in low serum calcium level, high magnesium level, and when serum calcium level is low, parathyroid hormone increased in the blood, which causes reabsorption of the calcium from kidneys and GIT, as well as from bones. So when calcium level in the blood decrease, bone become demineralized, and calcium is released into the serum, into the blood, and kidney reabsorb more calcium, and from GIT calcium is absorbed as well. So this is the physiology. And parathyroid hormone has following function: it activates osteoclast to reabsorb bone, increases calcium reabsorption from the urine, and renal activation of vitamin D requires calcium reabsorption from gut. So it increases renal excretion of phosphate. When calcium is increased, phosphate is decreased, or when calcium is decreased, phosphate is increased. So it increases level of excretion of the phosphate, means increase calcium, decrease calcium, increase parathyroid hormone causes increased excretion of the parathyroid phosphate from the kidney. The net effect increases serum calcium and decreases serum phosphate. So this is the physiology of the parathyroid gland. Now, calcitonin is another hormone which is synthesized by parafollicular cells of thyroid gland. It acts as antagonist of parathyroid gland, means when excess of parathyroid gland is secreted in any malignancy or any other secondary underlying cause, calcitonin acts as antagonist to parathyroid gland. It decreases serum calcium level, and it decreases calcium bone resorption in osteoclast, inhibits and it increases calcium and phosphate excretion. So calcitonin works opposite to the parathyroid gland. Now, the pathological conditions of the parathyroid gland are hyperparathyroidism. Hyperparathyroidism is of different types. Primary hyperparathyroidism means there is defect involving in parathyroid gland itself primarily. That's why known as primary hyperparathyroidism. It releases to spontaneous excessive parathyroid production by parathyroid gland. It affects women more than men, and prevalence increases with the age. Associated with the MEN, multiple endocrine neoplasia type 1, are also known as Vermeer's syndrome, and multiple endocrine neoplasia type 2 as well, which is known as Sippel syndrome. Now here we have to look at that what is MEN1 and MEN2. Multiple endocrine neoplasia type 1 and multiple endocrine neoplasia type 2. Multiple endocrine neoplasia type 1 includes the adenoma of pituitary gland, pituitary parathyroid gland, and pancreatic gland and pancreas. And the multiple endocrine neoplasia type 2 involves parathyroid, thyroid, and these two main glands are involved in multiple endocrine neoplasia type 2 and multiple endocrine neoplasia type 1, involved in pituitary, pancreatic, and parathyroid. When this disease, which is known as Vermeer's disease, Vermeer's syndrome occurs, pituitary gland is oversecreted, parathyroid hormone is oversecreted, and pancreatic hormones are also secreted, which includes glucagon, insulin. So symptoms are according to the release of the gland. So these are the Vermeer syndrome and Sippel syndrome. Okay, so now coming to the hyperparathyroidism, there may be cause. And the causes of hyperparathyroidism are single adenoma of parathyroid gland. Most commonly is 85%, are parathyroid gland hyperplasia, which affects all four glands. Parathyroid carcinoma can be there, and multiple adenoma can be there. So neoplasia is uh, most common cause of the hyperparathyroid gland. Now, in as we studied the function of the parathyroid gland is calcium regulation. In hyperparathyroidism, calcium is increased in the body. So, increased calcium in the body, patient will present with certain clinical features like stones, bones, groans, and moans. Stones means renal stone, and calcium based renal stone, and calcium is absorbed from the kidney tubules, and excessive calcium causes stone formation in the kidney. Bones includes excessive demineralization, which causes aches and pains at localized large joints like hip joint, knee joint, wrist joint, elbow joint. So localized pain at the joints, and groans include GI symptoms such as abdominal pain and constipation and pancreatitis. Constipation because of hypercalcemia. Hypercalcemia causes constipation, and patient with hyperparathyroidism present with the constipation, GI upset, and pancreatitis means epigastric pain. Moans include psychological symptoms which is also associated with the calcium level such as depression and lethargy. Patient will become lethargic. So these clinical features are enough to diagnose the patient of hyperparathyroidism, and if diagnosis is done, then patient is treated according to the diagnosis. And diagnosis is performed by increased serum calcium level and presence of normal elevated parathyroid hormone is diagnostic feature. Hypophosphatemia and elevated urinary calcium excretion are confirmatory. In hyperparathyroidism, there will be hypocaloremia, decrease hypercaloremia, and normal vitamin. Hypochloremia is there, normal vitamin D level will be there, and imaging should also be performed in order to diagnose. High frequency neck ultrasound identifies 75% of the enlarged glands. CT and MRI should be performed. Our cystectomy radioisotope scan is performed used to localize the adenoma and identify 75% of the adenoma of the parathyroid gland. It also focuses approach minimally and invasive parathyroidectomy. So that was the diagnosis of hyperparathyroidism. Now we have to look at the condition which is known as familial hypocalciuric hypercalcemia. Familial hypocalciuric hypercalcemia is hypocalciuric includes decreased calcium excretion in the urine and increased calcemia in the blood. Trait is autosomal dominant and it is defect of gene missense mutation is there in the cell membrane of the calcium receptor. That's why there is hypercalcemia. Biochemistry shows that elevated serum calcium level and parathyroid hormone level likely primary hyperparathyroidism. There is difference between primary hyperparathyroidism in which low urinary calcium excretion is there, and that's why known as hypocalciuric, low excretion of the kidney, and hypercalcemia means increased calcium in the blood. Treatment is uh, serum calcium not that high in these patients, so there is no treatment. Particular treatment is not there, but parathyroidectomy can be done except in neonatal cases. So parathyroidectomy can be done in these patients in order to achieve normal state of the calcium level. Other surgical treatments are parathyroidectomy, removal of the parathyroid gland. Surgically parathyroid glands are removed. Surgical indication in the patient is the primary hyperparathyroidism and reduced bone density, and previously asymptomatic means osteoporotic vertebral compression and fractures occurs because excessive demineralization of the bone. High serum calcium level will be there greater than 1 milligram per deciliter, and estimated GFR will be less than 60 milliliter per minute. Nephrolithiasis, kidney stones can be there. 24-hour urinary calcium excretion will be greater than 400, indicates primary hyperparathyroidism, and age of the patient will be less than 50 years. So these are the surgical treatment, and imaging study do not identify the position of the adenoma, so bilateral neck exploration should be performed and visualization of all four glands with excision of the enlarged one. And imaging studies shows the position of the adenoma. If it is shows, then focus the neck exploration and excision of the adenoma should be performed, and parathyroidectomy should be performed. So there are two types of the parathyroid surgery. One is subtotal parathyroidectomy and another is total parathyroidectomy. And subtotal parathyroidectomy, it involves removal of third and half gland, and total parathyroidectomy removal of the all glands. However, small amount of parathyroid tissue is implanted in bronchoradialis muscle of the foramen. It is known as autoimplantation. So this is these are the types of parathyroidectomy in which parathyroid glands are removed. So we discussed about hyperparathyroidism, primary hyperparathyroidism. In primary hyperparathyroidism, what clinical features can one find? These clinical features include excessive calcium reabsorption from the bone results into bone pain, stones in the kidneys, groans means GI upset, abdominal pain, constipation, and pancreatitis will be there. Modes include psychological changes like depression and lethargy. Patient will become lethargic. Or if we summarize this session in clinical vignette, so we can say a patient, a 45 or 43-year-old woman patient comes to the uh, clinic with the pain in the back and pain in the joints like hip bone and wrist joint, hip joint, and knee joint, and she has also constipation, abdominal pain, and epigastric pain with depression and lethargic. So what can be suspected? So we can suspect of hyperparathyroidism by these clinical features. So that was hyperparathyroidism. In the next lecture we will study different types of hyperparathyroidism like secondary hyperparathyroidism and tertiary hyperparathyroidism.